My name is Tim Williams. I'm a GP and a community pain specialist, and these are my 10 top tips towards self-management of persistent pain in primary care. Self-management with confidence is the aim. It's not you, it's them. Actually, when I realised that patients had much more of a responsibility to manage their pain condition, I felt that I could really relax and a huge weight was lifted off my shoulders. I realised that actually my job then was to support the patient find their own ability to respond to their condition. I did use other resources, self-help resources such as the Pain Toolkit, which I found very helpful, and they will be available in your resource pack. Patients with long-term conditions use on average about 3 hours of healthcare time in 12 months. That leaves 8,757 hours for them to self-manage. To not teach people the skills necessary to self-manage during that time seems to me a missed opportunity. My second tip is to expect persistent pain to be a long-term condition. So take your time. Persistent pain is not just acute pain which has gone on for a bit too long. It has been suggested that there are changes that happen in the central and peripheral nervous system which actually make persistent pain an utterly unique condition and a long-term condition in its own right, like diabetes or asthma. Accepting that premise helps both the practitioner and the patient move much more towards a position of attempting to find control rather than cure for their pain symptoms. This takes time, and perhaps the worst thing that someone could do on an initial consultation is simply to give more medication. Listen to the pain story from start to finish. As soon as I realise that a persistent pain problem is being described, I will often stop the patient and I will say, could you tell me today how you've got to this point, and I will book another appointment for you in a week's time and we'll work out where we're going to go from here. I haven't had a single patient refuse. I will then ask for the pain story in a logical order and I will say, can you tell me about your pain problem from when it started, how it's progressed, and then finish with how it is now. In that way, you'll get a really easier, straightforward chronology of the pain problem. You'll be then clear whether this is a new problem or actually something which has been going on for a long period of time. I will also want to find out what investigations people have had and what treatments they have had, which have either been successful or otherwise. My fourth tip is to form person-centered goals for the future. In line with moving towards self-management, it is important for the patient to be coached on setting goals for the future as they gain more control of their pain symptoms. Many of you will be familiar with SMART goals. Most patients will not. It may not be necessary for you to go through each of these steps, but goals should be specific and achievable and measurable. The success of achieving these goals will go some way to assessing the effectiveness or otherwise of the interventions that you choose together. One of the things I found really useful to explain persistent pain concepts to patients is metaphors. It's important for patients to understand what is quite a complex and poorly understood condition. More details about metaphors can be found in your resources. Useful concepts for patients to grasp at an early stage would be those around the pain cycle and also pacing. Describing the boom and bust cycle of poorly paced behaviour is particularly good rapport building tool, as most patients can recognise themselves in that behaviour and appreciate that you have some insight into their experience of living with pain. So, tip 6, keep analgesia simple and effective. Prescribing in persistent pain can be really tricky. When I prescribe, I follow these steps which I found extremely helpful. And I ask myself the question, is this medication safe? Really with respect to the other conditions that the patient has and also other medications that they are taking. bearing in mind that any medication you prescribe is likely to be needed to be taken long term. Tolerable. Can patients tolerate the side effects of the medication? Certainly, patients will not take even very effective medication if they can't tolerate the side effects. Some side effects, such as feeling drowsy or woozy-headed, may settle as patients continue to take the medication. Other problems, such as constipation, sometimes will not. And actually giving patients medication to help with those side effects can help them adhere to the medication. Effective. Do people take medication which is not effective? Well, in my experience, yes, and lots of it. And when you ask patients whether medication is effective or not, they often say, well, I don't know, doctor, because I take it all together. Sometimes they think the medication is not doing anything at all. I will often then ask, well, how about we reduce some of this medication and see what happens? Sometimes patients will react and say, well, don't do that because my pain will be much worse. And I think we can then take a step back and say with some confidence, in my experience, what tends to happen is that the pain stays about the same, but actually the side effects tend to settle. Patients might then be willing to try reducing medication. You can reassure the patient by saying, well, look, if your pain does get worse, you can restart that medication. And then know that you're actually taking something which is useful for you. Patients are then willing to give reducing the medication a try. Priced right. Is the medication cost effective? Is the patient getting the benefit for the cost of the drug? I think this is really crucial and something that we are all aware of as GPs. And I think we need to be conscious of that when we are prescribing. Simple. It is difficult for patients to be thinking about anything else other than their pain when they have to take out 16 to 20 pain-relieving medications with them for the day. What we're trying to do in persistent pain management is to shift the focus away from pain towards other aspects of life. It is sometimes therefore easier if we can prescribe something at the beginning of the day which is longer acting, and then they can take something else at the end of the day. And actually keeping things simple can be a really useful strategy for patients to manage their pain symptoms. Neuropathic pain may require special attention. Neuropathic pain, which arises from damage to the nervous system itself, may coexist with pain arising from the tissues, and it does not respond well to standard analgesics. Often patients will use descriptors such as shooting pain or stabbing or electric shock type pain or numbness and pins and needles, and we should be alert to that. Sometimes patients may say, I can't really explain it, doctor, and that always makes me think, could this be a neuropathic pain they're trying to explain? NICE have published recent guidance on the pharmacological management, which can be found on their website. But as always, pain medication is only part of the picture. Ask about life. It's not all about the pain. Initially, patients and healthcare workers can be utterly focused on reducing the pain symptoms. We should not ignore the fact that pain has a huge effect on life. It can be sometimes much more useful to pay attention to these other areas as it does shift focus away from pain symptoms. These include sleep, exercise, mood, weight, and even eating well. Self-care resources such as the Pain Toolkit can be extremely helpful for patients, and we as healthcare professionals can guide patients to them. Tip 9. Give strong opiates with extreme caution and careful review. Prescribing in persistent pain without a plan is pointless. Prescribing strong opiates without a plan is an absolute disaster. Prescribing strong opiates must be part of a clear strategy to realise goals. This is not palliative care. This is not about easing suffering in the last few days or hours of life. This, to my mind, is about rehabilitation. I would never prescribe short-acting opiates. Guidelines in prescribing can be found at the British Pain Society, and it would be well worth looking at these guidelines if you decided to go down this route. If I decided to prescribe strong opiates, my normal practice would be to start a trial up to 8 weeks. I would start extremely low in the dose and go extremely slow in titrating up. I would always be guided as to whether patients were achieving their goals, whether they were doing more than purely being based on the pain score. Careful and regular review is absolutely essential, and if the patient is not progressing along the lines of their goals, then we should be very much prepared to decrease and to stop the strong opiates. My final tip is to encourage continuity and limit the number of involved healthcare professionals. Having taken the time and effort to support your patient towards self-management, guard their follow-up jealously. Don't let other people get involved, make unnecessary referrals, changes to medications which will not yield any benefit. Promote self-management and teamwork. So, in summary, these are my 10 top tips. Self-managing with confidence is the aim of management. Expect persistent pain to be a long-term condition, so take your time. Listen to the pain story from start to finish. Form person-centered goals for the future. Metaphors can be a really useful way to explain persistent pain problems to patients. Analgesia should be kept really simple and effective. Neuropathic pain may need special attention. Ask about life. It's not all about the pain. Give strong opiates with extreme caution and careful review. Encourage continuity with only a limited number of healthcare professionals. Using these 10 top tips has made a huge difference to my medical practice, and more importantly, has helped patients with persistent pain self-manage with confidence.